Good morning, everybody. We will be taking a young master's course on alarm bell situations in cataract phacoemulsification surgery. So basically, what we are going to show you in this course is we are going to show you alarm bell situations that one can encounter during any step in the phacoemulsification in different challenging case scenarios. So I will be taking up in alarm bell situations in challenging cataract cases, whereas Dr. Trupti Madholkar, she will be talking on my difficult anterior and posterior capsule related alarm bell surgical scenarios. Dr. Om Prakash, Rohit and Cyrus Mehta could not make it, so they have sent their videos. So I will be showcasing those videos also later on. So I'm handing over the presentation to Dr. Trupti ma'am. She will be talking on anterior and posterior capsule related alarm bell surgical scenarios. Over to ma'am.
Good morning, everybody. Let's begin the first session of the last day of AIOC 2023. I'll be talking on my difficult anterior and posterior capsule related alarm bell surgical scenarios. This is a case of a fibrotic cataract. We see fibrotic cataracts very commonly in our region with very hard cataracts and calcified anterior capsule. A flax was planned in this case, and the patient was posted for toric IOL implantation. The fellow eye of this patient is pseudophakic, and we can see a optic capture. So maybe a PCR had occurred in the fellow eye. So we are keeping in mind that maybe in this eye there is a posterior polar cataract. So the plan of surgery is to post the patient for a flax capsulotomy and then do a phacoemulsification and be cautious of a PCR. We'll see what are the advantages of flax in such fibrotic cases. In patients who have a fibrotic cataract, flax has a distinct advantage because it is a closed chamber procedure. Flax capsulotomy in fibrotic cataracts makes it easier to cut over the capsule and cut the fibrotic bands, because if we start a manual rhexis, initiation of the rhexis is very difficult and at times it tends to run to the periphery. Also, we need to give multiple cuts with scissors and the rhexis is not complete, so then it becomes very difficult to do a phacoemulsification. With the use of flax, the laser energy and the incision depth can also be increased in dense fibrosis. Also, we are going to use the technique of differential IOP. In differential IOP, we are going to use the different IOP settings, that is a physiological intraocular pressure between 18 to 22 millimeters of mercury, supraphysiological IOP between 23 to 34 millimeters of mercury, and the sub-high IOP between 35 to 45 millimeters of mercury. Here we can see that how by adjusting the IOP, we can adjust the safety profile in presence of the alarm bell situations. Now let us go to the video now. Here we can see that it is a fibrotic cataract, a calcified capsule, and the staining is done under using our own technique of 30 gauge needle under the air bubble, which will be discussed later on by Dr. Tushya. Here we can see that 80% of the flap is separated, but some of the flap it still remains, and when we try to separate it, we can see that there is a stretch on the zonules. At this point, a microvanous scissors is used and the flap is cut with a microvanous scissors, and remaining flap is then removed with the rhexis forceps. Now the cataract is very dense, so a short and deep trench is made, and using a sharp chopper with a single go, the two heminuclei are separated, they are chopped. We can see that there is good lateral separation on one side. Now the nucleus is rotated and the remaining lateral separation of the heminuclei is made. Everything has been going on fine till now. And at this moment, here you can see that there is a underlying PCR which is noted. Now, what to do at this point? There is a bulky nucleus which is present in the bag. The CCC is intact, but a central PCR is there. So now what to do? At this alarm bell sign, after this alarm bell sign, what we have decided is to change the IOP settings, to go to a lower IOP settings. Do not rotate the nucleus. Continue with the phacoemulsification in a very slow motion manner and use a IOL scaffold so that the nuclear fragments do not drop into the vitreous cavity. The plane of emulsification will be at a slightly higher level, supracapsular emulsification, and we can do a IOL capture later on. Toric IOL plus or minus, it has to be decided on table depending upon the capsular status. Now we continue with the surgery. See, you can see a underlying PCR there. One fragment or one heminucleus is held with a lower settings. The settings which were there at sub-high IOP have been lowered down. By doing cross-chopping, the nucleus is divided, the heminucleus is divided into two chops. And by gentle movements, in a very slow motion, this piece is emulsified. Throughout the surgery, you can see that the chamber has been maintained very stable, and in spite of an underlying PCR, these fragments are not being pushed posteriorly into the vitreous and no vitreous is coming anteriorly. Now the remaining heminucleus is there, which is gently rotated so that it comes in front of the phaco probe, and getting an edge, it is held. Sorry. Let us see it once again. Here you can see the first fragment which was held properly, and then it was cross-chopping was done. The chamber has been stable throughout at this IOP settings. At a higher IOP settings, what happens is the chamber deepens and the nuclear fragments are pushed posteriorly. But this doesn't happen when we use a IOP of about 20 to 22 millimeters of mercury.
And the other thing is, you can see that due to the low IOP, there's a minimal pressure differences between the interior and posterior segment. So you can see the nucleus is just floating in the interior chamber. Yes. It is not pushing behind. So low IOP settings is a very useful tool. Yes, ma'am, you can continue.
Yeah. Now the remaining heminucleus is brought, and now it is divided gently by the cross chopping. At this point, it was decided that we will use the IOL scaffold technique so that these fragments are not pushed posteriorly. We have introduced viscoelastic substance through the side port so that the anterior chamber does not collapse, and now a multi-piece lens is introduced into the sulcus. The IOL scaffold technique is very good because it gives the surgeon the liberty to work at a deeper plane, and the corneal endothelium is protected at all times. Also, this IOL acts as a barrier. It acts as a posterior capsule so that the nuclear fragments are not dropped into the vitreous cavity. The IOL can either be dialed into the AC, and then the nucleus can be emulsified, or it can be put into the sulcus as we had put, because an IOL is there these fragments do not go posteriorly. We can see that the fragments were emulsified very easily. We have to keep in mind that the chamber has to be stable throughout the surgery. So before withdrawing the phaco probe, viscoelastic has to be introduced. Now the IOL is dialed into the position in the sulcus. And we believe that whenever there is a posterior capsular rupture, a single piece IOL should not be implanted and a multi-piece IOL should be implanted for the safety, long-term safety, so that there is no UGH syndrome. Now triamcinolone acetate is introduced into the chamber and we see that there is no vitreous in the anterior chamber and the surgery has been successfully completed. In the post-op period, it is very important to closely watch the patient for any inflammation or intraocular pressure rise, and a VR consultation is mandatory to see for any posteriorly dislocated fragments which may be otherwise missed. A good visual acuity of 20/20 with a cylinder of minus 1.5 diopters was achieved in this case. Now we go to a second alarm bell situation in which it was a very routine cataract, routine NS1 cataract, and the pupil size was moderate. It was around 6.5 mm of pupil. The biometry was normal, non-myopic eye, 18-19 diopters of IOL power. Let's see what happens in this case. The surgery is started. A postgraduate fellow is doing the surgery. A good CCC has been done and hydrodissection has been done. The wave of hydrodissection fluid is seen, which indicates that the nucleus is separated. Now trenching is begun. Now we can see that it is a very soft cataract, and yes, what happens here? You can see a round punch in the posterior capsule. The surgeon is oblivious to this and the surgery is continued and trying to separate the nuclear hemispheres, and we can see at this point it is realized that something is wrong. We can see the exaggerated glow. So a PC rupture has occurred while trenching. Very importantly, viscoelastic is introduced to the side port and then the phaco probe is withdrawn. What next? At this place we have the entire nucleus, and at the first step itself during trenching there is a PCR. Either we can convert this case or we can continue with phacoemulsification and keep the option of IOL scaffold in mind. What was our plan? The plan was, because the CCC is intact and it is a soft cataract, we will do the phacoemulsification at the low IOP settings. We will not rotate the nucleus, implant the IOL if possible, and change to IOL scaffold if required. Now, what is this low IOP? The physiological IOP is from 18 to 22 millimeters of mercury, and in this settings we use the AFR of around 23 in the sculpt mode and 26 in the quadrant mode, whereas in supraphysiological it is from 24 to 34 millimeters of mercury, and the AFR of 23 is used in the sculpt mode to 35 in the quadrant mode. By using these IOP settings, we achieve a very good stability of the anterior chamber, and the problems of deepening of the anterior chamber or hydration of the vitreous or loss of the fragments or the fragments moving posteriorly is not seen. The nucleus almost floats as it is where it was in the anterior chamber. Now the case is taken over by the senior surgeon. Because the trench is very deep, by a slight nudge, the two nuclear hemispheres have been separated, and gently with the stable anterior chamber, the heminucleus can be emulsified. See, the nucleus is just floating where it is. It is not going posteriorly in spite of having a PCR centrally. Now the remaining heminucleus is also just nudged. It is brought in front. No vigorous rotatory movements are made, otherwise these rotatory movements will cause the mechanical dislocation posteriorly. And this nuclear hemisphere is also emulsified very stably. The plane of emulsification is slightly anterior to what it might have been in the absence of PCR. Now again viscoelastic is introduced in the anterior chamber, and after that the probe is withdrawn. Now we have the cortical matter remaining. How to remove the cortical matter? Either we can use the irrigation aspiration, a coaxial irrigation aspiration, or we can use a bimanual. But before that, we tried to convert the PCR into a PCCC. It was not successful. The remaining cortical matter was aspirated using a coaxial IA probe. We can also use a bimanual IA in this case. Here what we do is, while using a coaxial, we slightly withdraw the sleeve of the irrigation so that the irrigation and the aspiration are at different levels. The cortical matter which was farthest from the rent was removed using a coaxial IA, whereas which was there in the area of the rent, that was removed using dry aspiration technique. Now the multipiece IOL is implanted in the sulcus, and we can do a optic capture. So these are the two alarm bell situations. See, this was the alarm bell sign in which the phaco punch occurred, and using the low IOP settings, we could complete the surgery successfully without enlarging the tear nor causing any dislocation of the nuclear fragments posteriorly. So we have to keep in mind about the settings which we are using, and definitely think of going to a lower settings to maintain a stable anterior chamber. Now Dr. Tushya will discuss the next alarm bell situations.
Thank you so much, ma'am, for showing such beautiful videos and enlightening the concept of differential IOP, more of low IOP phacoemulsification, which has so many advantages in a case with a pre-existing PCR or a PCR occurring during the phacoemulsification. So this differential IOP concept has just recently been awarded in the American Society of Cataract and Refractive Surgery. So I'll be showing you few alarm bell situations that you can encounter in the cataract surgery. So alarm bell situations can be radial tears, radial anterior capsular tears, which can occur at any stage in phacoemulsification, primarily occurring during phacoemulsification or during capsulorhexis or at any step. So these are the predisposing factors for an anterior capsular tear, like the white intumescent cataract. Then you have pseudoexfoliation, weak zonules, shallow anterior chambers, pediatric cataracts, fibrotic cataracts. So I'm just going to tell you a basic prevention strategy called the Little's maneuver, how you have to do if you are feeling that the capsule is going towards the periphery. So in this video, if you can see, I'm trying to make the rhexis, and I realize that it is going towards the periphery. So what should I do at this point? I should first of all inflate the chamber with the viscoelastic so that the iris lens diaphragm becomes concave. Then I'm going to show you how to do a Little's maneuver. So I'm injecting the visco, making sure that the anterior chamber is fully deepened. then holding the capsule from the root of the tear. And you can see this vector. So if you see the line of the tear, we have to pull the flap, the capsular rexus flap 100 degree to the direction of the tear. So this is Little's maneuver. So if you pull it 100 degree towards the direction of the tear, it will be pulled back. So you can see it is going towards that direction. So I'm pulling it 100 degree from the direction of the tear, and you have to not pull it vertically. You have to pull it horizontally over the capsule. So you can see how the capsule rexus is brought back. So this is another case which we can encounter is, you can see here I'm trying to do the rexus and suddenly I realize it is going towards the periphery. So what I did here, I injected the visco in the line of tear. So you can see after injecting the visco, it extended further. What I should have done was I should have injected the visco on the opposite side of the flap, so that the flap lies flat on the capsule and not injecting in the line of the tear. So you can see it has extended further. So what do I do now? So I use the help of Vanna scissor. I make a nick on the other side, and then I try to complete the rexus. So you can see the rexus is completed. Another alarm bell situation is a situation where you can have a Argentine and flag sign, especially in a white intumescent cataract. So these are few things which you have to keep in mind while you're doing rexus in white intumescent cataract. Use a viscocohesive. A micro forceps or a micro incision should be used. Why? To prevent any egress of viscoelastic from the interior chamber. So you can see in this case a micro incision, and usually what we used to do, this is a very old video where we used to give an initial curved puncture. Why? When you give a curved puncture, it gives the flap a direction. So you can see, and then you can complete a small CCC in the center. A small capsular rexus is done, and then followed by aspiration of the cortical fluid by debulking, and then enlarging in the debulk part with the Vanna scissor and completing the CCC. So what we realized was that we debulked the cortical fluid from the center, but you always had cortical fluid in the peripheral part of the capsule. So this can also lead to a Argentinian flag sign. So now what we have done is we are using a 30 gauge needle decompression. It is a closed chamber cortical decompression. You can see how I'm aspirating the fluid from the center. So the center part is all debulked part. So I make a rexus in that central debulked part. So then you do capsule milking. So what is this capsule milking? So we are gently massaging the capsule from the periphery to the center, so that the fluid in the mid periphery is taken out from the center. So you can see the fluid is coming out. It is, the peripheral part is also getting debulked. Now next step is doing the aspiration of the remaining cortical fluid. That is called cortical debulking. And then you can enlarge your incision, and once this is done, it acts as a normal capsule. So again, a closed chamber 30 gauge needle decompression from the center, so that the central part is debulked, then making a round rexus in the debulked part, doing capsule milking. It is being described by Professor Chi. So you can see the fluid is coming out from the center, then aspirating the remaining fluid, and then doing the final rexus. So this is another case, alarm bell situation in a white intumescent cataract. So again, what I did here, I could see that it is going towards the periphery, but what I did, I injected the viscoelastic in the line of tear. So you can see it is getting extended. So it was an initial video. Again, I injected, which was wrong. What I should have done is I should have injected the viscoelastic from the other side of the flap, so that it could lie flat on the capsule. So if you end up into an Argentinian flag sign, so what is the management strategy? So I'm just going to show you a video which had won in 2018 American Society.
Old case of white.
So can you increase the volume?
With interior chamber depth of 2.4 mm. I tried to carve out the rexus, and there was an Argentinian flag sign. What do we do now? I inflated the chamber with viscoelastics and regularized the capsule rexus. I preferred chop technique with first chop done without much separational forces and not 90 degrees to the tear. At the same time, my focus was on trypan blue stained anterior capsular tear. It was fluttering and everted. Nuclear emulsification was done at iris plane. Fluttering flap meant 100% flap tear had not extended beyond equator. That gave me full confidence to continue the surgery with safe phacoemulsification technique. Had the flap become inverted and non-fluttering, it would have meant that the tear had become wraparound post-equatorial tear. There were minimal separational forces applied again. I also avoided sudden collapse or deepening of the chamber. My phaco parameters were on the lower side. Flap was still everted and fluttering. The initiation of rotational forces were minimal and were done keeping in mind that the rotational force did not put stress to the extended flap. Last nuclear piece was eaten and nuclear emulsification was completed with the continuous vigil on the everted nature of the flap. Cortical aspiration was done with lower vacuum, with the fluttering of flap tear kept in my visual horizon. I confidently implanted the IOL in the bag as I knew the posterior capsule was intact because of the flap motility sign in my armamentarium. Flap motility For better explanation, these animations show that the pre-equatorial tear is everted and freely fluttering in nature. Hypothesis for fluttering flap is that the end point of the extension of the flap functions as the pivotal point for the flap. The flap, being short, is responsive to the fluid dynamics of the interior chamber and thus flutters freely. But once the pre-equatorial flap extends beyond equator, the flap becomes inverted and stops fluttering. As there is a breach in the barrier in the event of posterior extension of the extended anterior capsular tear, there is pulling down of the anterior capsule tear. The pulling down is because of the combination of the higher pressure of anterior segment, increased capsular bag volume, and the negative pressure of the posterior segment that pulls down the back complex and makes the flap lie flat and eventually become inverted and non-responsive to fluid.
So this has been published by us few years back. So another alarm bell situation that you can get during capsular excess is in pediatric cataracts, as the elasticity of the capsule is high. So what you do is do a good capsular staining. When we do a good capsular staining, it often decreases the elasticity of the capsule. And another thing is always use a viscocohesive, and you can see you should do a centripetal maneuvering of the capsule. So centripetal maneuvering of the capsule, slow capsule rexes, good anterior chamber stability with using of viscocohesive, and a good capsular staining is very important in pediatric cataracts. So we often get these alarm bell situations in these cases like white cataracts, corneal opacities, cortical cataracts, when you have a inconsistent capsular staining. So a good uniform capsular staining is very important. So we have published this new technique few years back, which is a modified 30 gauge trypan blue staining technique under air for uniform and consistent anterior capsular staining. So what is this technique for uniform and consistent technique is? It is an under air trypan blue staining technique. We use a 30 gauge needle on 1 ml syringe for easier and safer manipulations. So it has three variants. So first is fill the interior chamber with the AC from the main port, and then you can see we are using a 30 gauge needle which enters the interior chamber through the peripheral cornea, Trypan blue is injected, a few drops, 1 or 2, and then a hold time of 15 seconds. It gives you a very good stable chamber, and there is no egress of fluid or air from the incision sites, and you can see it is well maintained and the staining is completed. And then saline or a viscoelastic is used to take out the air bubble, and then you can do a rhexis. Another variant of this technique is when you have ACD of less than 3 millimeters. So what we do is we take the proximal 0.05 ml of the syringe is filled with air instead of trypan blue dye. So this is a case with a low ACD. So you can see 30 gauge needle is entering from the peripheral cornea, and you can see air is injected before. So you can see how the anterior chamber is deepening first, so that you have a good under air, and then trypan blue is injected. So you can, the third variant is where you can use more than one drop whenever you have a inconsistent staining, so that to have a good uniform staining. So this technique is a cost effective, is easy, it has a good staining uniformity. You are using a very less amount of dye, time consumed is very less, endothelial toxicity is also very less, spilling of dye into the posterior segment is also less, you have a good anterior chamber stability, and there are minimal chances of iatrogenic trauma when you compare it with all other techniques. So another alarm bell situation that we can get during the phacoemulsification is iris prolapse. So iris prolapse, why is iris prolapse a problem? Because you can have a transillumination defects then due to the iris injury, and then you can see you can have polychoria, you can have glare from the edge of the lens, and then you can have iris incarceration also. So iris prolapse is a problem. So what are the different causes of iris prolapse? It can be due to the positive pressure, which is due to exogenous causes like a tight lid speculum or a drape, or vital or lid causes like deep socket or a low small palpable aperture, a retrobulbar hemorrhage, thyroid, endogenous causes like nanophthalmos, fluid misdirection syndrome, suprachoroidal, and then often you have conditions like IFIS or small pupil, which can also lead to an iris prolapse. And other procedural causes are like floppy iris, wound gape, rapid outflow, and high pressure. So I would define iris prolapse due to a tetrad of reasons. Those are floppy iris, wound gape, rapid outflow, and high pressure in AC. So floppy iris is due to the intraoperative floppy iris syndrome, which is seen in patients on tamsulosin. And when does wound gape occur? When an instrument is smaller than the wound, like a hydrodissection cannula, a capsulorhexis forceps, or if you have a tapered tip of irrigation sleeve, a phaco or IA, or when the wound is too large. When does rapid outflow of fluid occurs? It can occur during hydrodissection immediately after the fluid wave is created if you are doing a vigorous hydrodissection. If your irrigation is on while entering or exiting the main wound, or the flow around an instrument when the wound is too large, or if you are overinflating the anterior chamber with OVT. So our aim is not to have a high pressure in AC, because if you have high pressure, then there will be a iris prolapse. So aim is to create a negative pressure in the anterior chamber. How you can do it? By non-touch technique of repositioning that I will show you in the following video, where you just have to tap on the incision. Then hydrodissection. Always when you're doing hydrodissection, before taking out the cannula, decompress the fluid wave behind the lens by gently tapping on the lens. Release of aqueous or visco from the parasentences like side port, you can use and then release iris from the incision and try to deepen the anterior chamber. Always inject viscoelastic subincisionally. Avoid overinflation. Gentle tapping on the incision site. So what are the risk steps in cataract surgery where you can have iris prolapse? A short tunnel, lifting or depressing the roof or floor of the tunnel with the instrument, hydrodissection if you're doing it vigorous, there's a wound gape caused by cannula, fluid wave prolapses cataract anteriorly causing rapid outflow of OVD, and the iris goes with the flow out. Irrigation when it is on while entering or exiting, wounds which are too large, and a vigorous stromal hydration can also lead to an iris prolapse. So we have to think of each step ahead, because always remember iris has got memory. So if you have so I'm just going to show you few videos now. So this is a video where I ended up making a short tunnel. So I was doing the rexes and I was trying to complete the rexes, and you can see subincisionally, when I reached subincisionally, the iris was out. So what you do here is I was gently trying to push the iris back. Always inflate the viscoelastic just above the iris, remembering not to overinflate the interior chamber. But then when I again started my rexes, again the iris was out. So always remember, iris has got memory. So from the side port, I took a iris hook. I was trying to take it in, but again it came out. So at times when you have short tunnel and the patient was of low ACD, so you can keep getting this iris coming out. So what I did, I made another incision. So I just made another incision, forgot about the previous short tunnel, and you can see now with ease I'm able to do the rexes, the hydrodissection. That is also, always remember not to overinflate the AC, and you can see I'm completing the case, doing the phacoemulsification with a new incision. So always make a new incision if you feel that your iris is coming out regularly. So wound, remember, it should not be too large, because if you have rapid outflow of the fluid, iris will come out. So you can see in this case, so the wound is too large, there is rapid outflow, and the iris comes out. So wound should not be too large, it should be calibrated according to the size of your instrument. So here is another case where I'm trying to, the IOL is implanted, I'm doing a vigorous stromal hydration, and you can see iris comes out. So what I do here, tap the iris. Gently tapping on the incision site can make the iris go back, and do gentle stromal hydro. So this is another case where you can see the irrigation was on and the iris started coming out. So always remember, irrigation should always be 0 or should be off while taking in or taking out of the instrument. So what I am doing wrong here is I'm overinflating the AC and iris comes out. So what do? I take the instrument from the side port, gently pushing the iris in, because you should be very gentle, otherwise you can end up into an iris sphincter tear also. So be very gentle in pushing it in. So you can see, so it is not coming in because there was high AC pressure. So what I'm trying to do is, I have realized that the anterior chamber pressure is high. So I'm gently depressing the main port to take out the visco from the interior chamber, so that the pressure reduces in the interior chamber. You can see the viscoelastic is coming out. So I'm gently tapping over the incision site so that the iris goes back in. So just gentle tapping on the incision site can also push the iris back into the AC. Then from the side port, depressing the incision to take out the viscoelastic. So I'm doing all these maneuvers to make sure that the interior chamber pressure is reduced. So adrenaline is injected to dilate the pupil. And then always remember that your irrigation should be off while entering. So irrigation was turned on once the probe was fully in the interior chamber. And phacoemulsification is done. Whenever you are taking out, always remember irrigation should be off. Injecting visco, always remember not to overinflate the interior chamber. Just a subincisional injection of visco over the iris can push the iris back. Then IA, always remember entering irrigation off and irrigation off while exiting. So another alarm bell situation that you can get is, so this is a case of 72-year-old patient with absorbed sclerotic cataract with partially empty bag and Zoller dehiscence. So you can see in this video, I'm trying to make a nick. Because of weak zonules, I'm not able to make a nick. So what do? I take a help of sharp cystitome to just make a nick on the interior capsule. So now I'm trying to make a rhexis. So I have two options. One is I can use a bimineral rhexis where the second hand instrument gives a counter traction to complete the rhexis. Or what I can do is I can take the help of a capsular hook, which also gives a counter traction to complete the rhexis in weak zonules. But to my luck, I was able to complete the rhexis with the capsular rhexis utata forceps. So gently I could complete the rhexis. So the rhexis was completed. And now you can see, while I just started doing direct chop, you can see zonular dehiscence on the right hand side with the arrow. So I could see zonular dehiscence there. So my phaco parameters were lowered down, gentle, slow motion phacoemulsification, making sure that not to weaken the zonules more. So now I have three options. I can use the help of capsular hooks, a CTR, or continuous phacoemulsification. So I did a zonular counter traction test. So I could find that I was able to rotate it. So I kept continued phacoemulsification. So I did the chopping, gentle chopping with minimal separational forces. Again, you could see that there was a zonular dehiscence noted while I was doing chopping, and you can see that this zonular dehiscence was seen in the area where it was devoid of the nuclear pieces. So you can see the zonular dehiscence here where the nuclear pieces were not present. So I divide gently, and now I have three options. What I can do is I can use the help of capsular hooks, a CTR, or a nuclear scaffold. So again, showing you that while I was doing phacoemulsification, I could see zonular dehiscence here. So I take the option of CTR. Why? CTR gives a horizontal equatorial support to the bag. And what I will do is I will take the help of nuclear scaffold. What is this nuclear scaffold? So this nuclear scaffold gives a three-dimensional support in the area of zonular dehiscence. So I'm gonna strategically always inject viscoelastic to make sure that the bag is properly inflated. Viscoelastic is injected, and then CTR is injected into the bag. It is injected at the site, from the site of zonular dehiscence. So this CTR gives a two-dimensional equatorial support to the bag. And now I'm going to strategically use the nuclear pieces. So I'm strategically positioning those nuclear pieces at the site of zonular dehiscence. So these nuclear pieces are giving a three-dimensional equatorial as well as a horizontal support to the bag. So I'm continuing phacoemulsification by keeping the hard nuclear pieces as nuclear scaffold in the area of zonular dehiscence. And you can see I'm continuing I'm again repositioning them to the area of dehiscence which I showed you before. I continue phacoemulsification by taking the help of nuclear pieces as a scaffold. So before taking out these last pieces, what I do is I use the help of IOL scaffold. So what I'm going to do is, before emulsification of the last few pieces, I'm going to inject the IOL in the bag. So again, the haptics of this IOL, I'm going to place them in such a way that they also give the circumferential two-dimensional support to the bag. So after placing the IOL, I continue phacoemulsification. You can see there's a peaking of pupil. So this means that there is some vitreous in the AC. So I'll be injecting a pilocarpine, and with the help of iris hook. So pilocarpine is injected, and then triamcinolone and anterior vitrectomy, and the case is completed. So this nuclear scaffold in hard cataracts can be used in generalized zonular weakness in subluxations less than 90 degrees. Additional endogenous support, as it provides an anterior posterior as well as a horizontal support. It cannot be used in subluxation more than 90 degrees, and it can be used as a combination of scaffolds. So this has been published by us few years back. So over to Dr. Trupti. So she's gonna discuss one more case regarding alarm bell situation in a anterior capsular or a posterior capsular surgical scenario.
Thank you, Dr. Tushya. Now I'll be showcasing posterior polar cataracts. Posterior polar cataracts is a scary situation for most of the phaco surgeons, more so when we can...
Can you put the video on? The video for, yeah, done.
Yeah. Posterior polar cataract is a scary situation for most phaco surgeon, and more so when we can see a pre-existing posterior capsular defect. Here we have a 41 years old lady with a posterior polar cataract, and we can see a pre-existing defect in the posterior capsule. The cataract is very soft NS1 type, and the patient has high expectations. When we do the anterior segment OCT, here we can see a moth-eaten appearance, which will indicate that the PC is dehiscent, and there is 99% chance of a posterior capsule rupture when such a finding is noted. On the slit lamp examination also, we can see clearly that there is an onion whorl appearance of the cataract, and if we see clearly, we can see two lines in front of and beneath the onion whorl, which indicates that the PC is dehiscent or the PC tear is there. Now, what is the surgical plan in this case? The main thing which is going to extend the posterior capsular tear, or which is going to push the nucleus into the vitreous cavity while doing the phaco, is the change in the intraocular pressure or change in the if the AC collapses. So what we have to keep in mind is that while operating a case of PPC, the chamber should remain stable during each step of surgery. And while we come out and go to the second step also, we have to be sure that the chamber is formed. So we are going to use stable chamber settings. We are going to use the lower IOP settings, which will be varying between 20 to 28 millimeters of mercury. The site of incision. How do we plan the site of incision? We have to take a look at the direction of the tear. Here, when the direction is diagonal, our site of incision should be 90 degrees to the site of the axis of the tear. In PPC, hydro procedures should not be done. No hydro procedures will be doing. We will not be rotating the nucleus, because anything, a fluid going inside will cause increase in the PC rupture, or if we rotate the nucleus also, that much movement will cause the nucleus to dip down. And we are going to use mechanical separation or visco separation if required, and we are going to do the dry aspiration of the cortex. This is what we have in mind when this surgery is planned, and a IOL capture can be done. How to plan the rhexis in this case, because this is the major step which is going to help us do a good phacoemulsification as well as place the IOL. In this case, we did a oval rhexis. Now, what is the advantage of an oval rhexis? Oval rhexis gives us the best of both worlds. That is, it gives us the advantage of a small rhexis, as well as it gives us the advantage of the larger rhexis, because in one axis it will be smaller in size, whereas 90 degrees apart where it is oval, the rhexis will be larger in size. The larger rexes will give us the advantage of no rise in the intraocular pressure. We can do a safe end-to-end sculpting, easy division of the nucleus, and also it becomes easy to remove the subincisional cortex, and the IOL entry can be very smooth. Whereas the smaller rexes gives us an advantage of the optic capture, and the nuclear fragments will remain in the bag, and if any vitreous, if it is coming, the smaller rexes will give a tamponade to the vitreous. So by using a oval rexes, we can have the best of both worlds. We can have a large rexes advantage as well as the small rexes advantage. Now the cases begin. We can see that it is a very soft cataract. We can visualize the tear also, which is there pre-existent. And being a very soft cataract, after doing a trenching, it is not possible to separate the nucleus. And now we are in a no man's land, what to do? Because PCR is already there, the nucleus is not separated, what to do? What we have done is, you can see that in the inlay, the IOP settings have been lowered down. The IOP is 30 right now, and we are trying to remove the nuclear fragments by mechanically separating them and then aspirating. At this setting, you can see that in spite of having a end-to-end PCR, pre-existing PCR, the nuclear fragment is just floating where it is, and it is not dipping posteriorly as one would have expected. Now visco is again introduced before taking out the probe, and to separate the remaining nuclear matter, visco dissection is done. Viscoelastic is introduced on two sides. Even subincisionally also we have introduced visco using a J cannula. Now this nuclear material is remaining floating in the AC. We have further lowered down the settings to 20 millimeters of mercury. Centurion machine is being used, and here we can see that at these IOP settings, 20 millimeters of mercury, the nucleus is easily emulsified. It is remaining just in front of the probe where it is not going posteriorly. No vitreous is seen, or the pupil, there is no change in the size of the pupil which may indicate that vitreous is coming in the anterior chamber, nor there is any deepening of the anterior chamber which may cause extension of the tear. Now the nuclear material is emulsified and only the cortical matter is remaining. Because there is a large tear, it is decided that dry aspiration of this cortex is to be done. We use a 25 gauge cannula, just slightly irrigate at the point where the cortical matter is there, tease the cortex, and then slightly by a tangential stripping, the cortex is removed from that area. It is not aspirated into the cannula, but it is slightly stripped off and taken away, and then removed with visco. Now staining is done with triamcinolone acetate to see whether there is any vitreous in the anterior chamber. No vitreous is seen, and we have decided to put the multi-piece intraocular lens in the sulcus, which could be put easily, and an optic capture is done. So even in a case of posterior polar cataract with a pre-existing tear, phacoemulsification could be done safely without extending the tear, without causing any posterior dislocation of the fragments. The patient had a very good visual outcome of 2020.
Thank you so much, ma'am, for enlightening us with the posterior polar cataract.
Yeah, one has to be very careful about the post-operative follow-up, because sometimes we tend to miss any fragments which may be dislocated posteriorly. So close watch on the inflammation, and the VR consultation is mandatory. Thank you.
So just few more minutes left. So I had a video of alarm bell situation in a Morgangian cataract. If you can put this on. So, alarm bell situation in Morgagnon cataract can be due to variably sized, freely floating nucleus. Why? Because there's a difficulty in holding of nucleus, and then you have no cortical or a epinuclear shield, so you can lead to a posterior capsule rupture. And then you have a hard nucleus, so you need higher fluidics, so you can have a post-occlusion surge and empty bag, leading to a fluttering PC and a PCR, and then there's zonular stress and back dehiscence. So this weak zonules can lead to capsular back dehiscence or a posterior capsule rupture, and plus the presence of liquefied vitreous, where you can have volume changes with the fluidics, and then which can lead to a fluttering PC and a PCR. So
This surgical video of a Morgagnian cataract demonstrates difficulty in immobilization of the nucleus due to the absence of cortico-epinuclear cushion. The animation showcases the technique to immobilize the nucleus by taking equatorial support of the capsular bag. This surgical video demonstrates how the nucleus is pushed towards the capsular periphery and immobilized. Once the nucleus is immobilized, it becomes easy to chop without any collateral damage. This is repeated for division of all quadrants. This is another case of Morgagnian cataract wherein the nucleus is gently moved towards the equator of the capsular bag and chopping is initiated. Continuous support of the equator is taken till division or chop is not complete. This is repeated for division of all quadrants.
So this technique has been published by us a few months back. And another thing what you can do in Morgagnon cataract is, as we know that there's a liquefied vitreous, there is fluttering PC. So you can see I'm trying to do the rhexis. Rhexis usually doesn't extend in a case of Morgagnon cataract because there is no compartmentalization and the intralenticular fluid is not that high. So I continued phacoemulsification before taking out the last piece. You can see how the capsule is fluttering, which can lead to a PCR. So I stop there. I do IOL scaffold. I inject IOL in the bag, which acts as a scaffold and prevents PCR while emulsification of the last piece. So this technique was also published by us a few years back, and I think the time is over. We have 2 more minutes for any discussions. If anybody has a question, we can discuss. Can you switch on the mic there? We cannot hear.
Yeah, now it's switched on. There was a PC rent pre-existing and nothing dropped. The antrahaloid face is very much intact. Suppose it dropped.
Ma'am, can you switch on the mic? Can you switch on the mic, ma'am? There.
The mic, ma'am.
So that's a very good question.
Yeah.
Ma'am would like to add.
Yeah, see, if the nuclear fragment drops, then we have to follow the protocols which we have to follow in such cases. We have to do a good anterior vitrectomy.
Through pars plana.
Whatever is, it will be.
Vitrectomy is through pars plana.
Yeah, okay.
Yeah. A few things I would like to suggest. From this platform, only those things should be delivered which are possible in the corners of the country. Suppose a fragment drops, and this is a big problem. You are a very expert surgeon. The other surgeons may go with the probe, not realizing where they are. And they pull vitreous and create a cascade of events finally leading to blindness. It is very much possible, and many times it does happen.
I think
That's a
It
very
is
good
not
suggestion.
a big issue. Just that's a simple cataract. Enlarge the incision. It's a soft cataract, and take it out. Put one suture. The pain of a vitreoretina surgeon and anterior segment surgeon can never understand.
That's a beautiful
yeah,
suggestion.
I
I
think
just
it
want
is a
to
very
add
valid
one.
point. One should keep in mind it is very valid, but as a cataract surgeon, even in uneventful cases also we can encounter a nucleus drop or cortical fragments going into the vitreous cavity. So one should know how to do a good anterior vitrectomy and how to deal with the case, how to place the IOL, or whether
Yes,
not
sir.
to place, the decision making is important.
Yes, sir.
I think it's a very important, pertinent question. But what I want to clarify here is, if suppose you have a PCR and you have a quarter of the nucleus, half of the nucleus there, what I would suggest is use viscoat. The viscoat will act as a good tamponade for you. It will keep the anterior hyaloid back, and you can bring the nucleus up into the iris plane or in front of the iris in the presence of viscoat there. Once you have the viscoat there, then you can put an IOL, okay? And you can do an IOL scaffold and go ahead with the nucleus emulsification if you are okay. But I think viscoat plays a very major role in preventing this anterior hyaloid rupture as well. You can make sure that the anterior hyaloid doesn't rupture. I have got several videos I can show you, pre-existing posterior polar cataract wherein the anterior hyaloid is intact. Once you put the viscoat, they go back and you can actually see the anterior hyaloid there without...
Yes, sir.
Yeah, we can do the bimanual technique. You need to do that
Yes, sir.
for irrigation aspiration. But once the vitreous is there also, you can use tricot, remove the vitreous,
Yes, sir.
either the limbus or pars plana. Pars plana is more difficult for anterior segment surgeons, I understand, because you need to put a trocar and cannula. Limbal vitrectomy is fairly good. Only thing is you need to follow the certain protocols for that. It's not easy. It's not difficult at all. It's not easy also. There's a learning curve. But only thing is you need to do that.
Sir, I want to add one thing. So
Yes.
if you would have seen in that video, we did a low IOP phacoemulsification.
Yes.
So the advantage of low IOP phacoemulsification, we are using 20 IOP and aspiration rate of 25. So what has happened is there is a minimal pressure differences between the anterior and posterior segment. So you could see how the nucleus was floating. There was minimal infusion of fluid because to prevent any vitreous hydration. So the size of the PCR also remained the same. And there was and you could do so. Another important thing for a successful low IP phacoemulsification, there should be no leakage in the side port also. So we used calibrated side port, so it had such a good chamber stability that you could easily remove the nucleus without any extension, without any posterior bulging of the capsule, and with the help of low IP phacoemulsification I could complete it. This video just won in ASCRS.
Yes.
So differential IOP. So
I've seen that video, Tushar, but it's very nice. Tushya, but this is very important. What he is asking is a very important question, wherein it should be practical from all corners of India. Okay?
Yes, sir.
Even a person who is in the rural setup, how do you manage? Okay? If you have a bigger nucleus, as he rightly said, extend the incision, do an SICS and come out.
Yes, sir.
Okay? And because you don't have access to a VR surgeon, or
Yes,
you are not a VR surgeon as well.
Yes, sir.
So that is a way to go. That is a take-home message I want to give. If it is a smaller piece, then you can follow all these protocols. Whatever
Whatever
I
you
told
suggested was perfect. We should
Perfect.
follow that.
Yes. This is a platform of India. This is a platform of India. Anterior segment surgeon can do stunts, but if one case goes wrong, I operated upon a case. My colleagues referred me. Patient was best corrected 6'9". Everybody can hear me.
Use the mic.
She operated upon, and there was a nucleus drop. By the time she could take out the phaco probe and realize what has happened, she had already made a tear. And we managed the case. The patient developed complications one after the another, and he's very nicely having hand movements now.
That's great. That's
great. If that happens to one, Can we excuse ourselves?
As you said, pars plana vitrectomy should be followed. That's a take home point.
Let me
So
tell
I think
everybody,
9 o'clock you need
I
the...
think as surgeons, all of us think of patient safety first.
No. Once you have a nucleus drop, don't chase the nucleus with your phaco probe.
Yes.
That is a question. The thing we can produce giant retinal tears and medico-legal issues, as you mentioned. So you just clean up the anterior segment. You can put an IOL and refer it to the VR surgeon, and they will do a pars plana vitrectomy and use a fragmentome and take the nucleus. Even the hardest of the cataracts, we can use a fragmentome now. Fragmentome is very good. We can remove the nucleus and we can get a good visual acuity as the end of it.
Thank you so much, sir. Thank you so much for suggestion. Now we'll move on to the next session as it's already 9 o'clock. Thank you. Thank you everybody for taking out time for the call.